Now, I welcome Shashi sir to introduce the topic and speaker for tonight. Welcome, sir.
Respected Brajesh, President of ISA Malappuram City, Frank Mosley, Nasser, Jalil, other dignitaries. I'm very thankful to the Secretary and President of IMA Malappuram for giving the opportunity to moderate a session of pediatric palliative care. Coming to the topic, pediatric palliative care is a topic that requires special attention. There are more than 16 lakhs children in India who are in limiting or life-threatening illness. The specialists in these fields are far less than that is required. To elaborate the topic, we have an authority in the field, Dr. SUDHA. She is an additional professor and HOD of palliative care medicine, RCC Trivandrum. She did MBBS, DA, and MBBS, MD, and DA from Government Medical College Trivandrum, Master of Hospital Administration from University of Kerala, training in palliative care medicine, fellowship training in interventional and pain management, onco surgical critical care, and acute pain service from major cancer institutes in USA. Professional life, she started as senior lecturer in anesthesia in TD Medical College, Malappuram, and continued the service in medical education department for a couple of years as senior lecturer in Department of Anesthesia, Government Medical College, Trivandrum. Joined RCC Trivandrum as a lecturer in anesthesiology and continued service as assistant professor, associate professor, and additional professor in the division of anesthesiology. RCC till 2020. Presently holding the designation of additional professor and head of the division of palliative care since June 2020. To enlighten us on the topic of pediatric palliative care, I invite Dr. SUDHA. Over to you, madam.
Thank you. Thank you. Good evening, all. So first of all, I would like to thank Dr. Munish and other office bearers of ISA Malappuram branch for giving me this opportunity to share my thoughts with you. So as a disclaimer, I would like to say one thing, that I am a new entrant to this field of palliative medicine. I got into the specialty just 20 months back, to be exact, on 1st June 2020. So my practical experience in pediatric palliative care is very limited. So I was a bit apprehensive and a lot more reluctant to take charge of the department. But now, to be frank, I regret not for leaving my basic specialty, that is anesthesiology, which I have been practicing for the last 20 years, but for being so late into this field. I should have got into this specialty of palliative medicine many years before, because this is the one specialty where I always do something. So, എനിക്ക് ഇത്തിരി ഇന്റർനെറ്റ് ഇത്തിരി ബാൻഡ്വിഡ്ത്ത് കുറച്ച് കുറവാണ്. ഞാൻ വീഡിയോ ഒന്ന് ഓഫ് ചെയ്യാണേ.
Meeting.
So now let us come to the topic proper. So what is slide sharing? Move ചെയ്യുന്നില്ല, നോക്കട്ടെ. ഒന്നുകൂടെ ഒന്ന് സ്റ്റോപ്പ് ഷെയർ ചെയ്തിട്ട് ഒന്നുകൂടെ ഷെയർ ചെയ്യാമേ. സ്ലൈഡ് സ്റ്റക്ക് ആയി തോന്നുന്നു. ഇപ്പൊ കാണാമോ? ഇപ്പൊ കാണാമോ? സ്ലൈഡ്സ് കാണാമല്ലോ അല്ലേ? Shall I start?
Yes, we can see the screen.
Screen
okay. Okay. So let us come to the topic for today's discussion. The word palliate comes from the Latin word pallia, which means cloak, C-L-O-A-K, and it is the care that cloaks or protects patients from distressful symptoms of the disease, like this dress which covers the whole body and protects the body from environmental hazards to some extent. And this palliative care is offered whether cure is possible or not. So what is pediatric palliative care? It is, according to Royal College of Pediatrics and Child Health, this palliative care for children is the active and total approach to care. It is active. That means it is not just simply stopping the treatment, and it is total. That is providing comprehensive care for the child, taking care of the physical, emotional, social, and spiritual elements. And the aim is to provide the best quality of life, not only for the patient, but also for the family. And this is by prevention, early detection, and treatment of distressing symptoms, provision of respite care, and care through death and bereavement. So it is not just tender, loving care. It is an evidence-based medicine. It is about treating the illness rather than the disease, because this illness includes the disease, the physical symptoms, the psychosocial issues, the spiritual problems, etc., which negatively affect the child and the family. So there is treatment directed therapy, because the disease process is also actively addressed, provided they improve the quality of life. So it begins when the illness is diagnosed and continues throughout the disease, irrespective of whether or not the child receives disease-directed therapy. And it requires a broad multidisciplinary approach that includes the family. And this care can be provided in tertiary care facilities, in community health centers, and even at home. So it is the comprehensive care which is provided throughout the child's illness and not solely at the very end of life. It starts from the day of diagnosis of the disease, and sometimes it starts even before the diagnosis, because it takes care of the fear of diagnosis, and it continues throughout the disease process in varying intensity according to the exacerbations and remissions of the disease. And as the child approaches end of life, the physicians, the treating primary physician says that there can be nothing more it can be done. Then the palliative care physician takes over the control and continues treating the child as intense as possible till the child dies. But the palliative care doesn't stop there. It extends beyond the death of the child, giving bereavement care and bereavement support to the family, because it takes care of the family also. So why do you need a newer specialty called pediatric palliative care? Because in children, nothing other than a perfect cure is accepted by the society. And so it is difficult to identify a point where treatment becomes exclusively palliative in children. And children, they are not miniature adults. They have different diagnosis, time scales, and symptoms. They are at different stages of development and growth. And due to this, communication issues and management needs in children, they are very complex and multi-layered. Modern pharmacological as well as technical approaches, they have resulted in longer illness trajectories. But despite these advances, many of these children, they present with slow deterioration towards a state of high dependency and disability extending into adulthood. And these children, they often have multiple symptoms requiring frequent medical interventions in addition to complex psychological needs. Many conditions are rare and the prognosis is quite unpredictable. And these children could die anytime, or sometimes they may live a number of years. So we don't really know how long these children need intensive palliative care for a reasonable quality of life. While the child is a patient, he is also a developing human being. So pediatric patients, in addition to the treatment, they need all the physical, emotional, and spiritual resources like a healthy child for his growth and development. The ethical issues are quite different and complex in children. Care of the sick child is considered as the duty of the whole family and even the wider community. So all the family members are affected in some way or the other because of child's illness. So it is important to care the carers. So parents, siblings, grandparents, they all need support in adjusting to the diagnosis and ongoing care of the child. These children often they suffer significantly due to inadequate recognition, underrating, and undertreatment of symptoms. And this is especially true in the case of very young non-verbal children who cannot express their sufferings, and they are not even able to resist physically. Even in tertiary cancer centers, painful pediatric procedures are still done under physical restraints. So death of a child is the greatest tragedy that can happen to the family. So bereaved parents, they suffer from intense grief and they themselves are at increased risk of death, both natural and due to unnatural causes. So the goals of CPC includes improving the quality of life by relieving the physical, emotional, psychological, spiritual, and social sufferings, coordination of care, facilitation of decision-making throughout the disease trajectory, assistance during transition from curative to comfort-focused care, and avoiding unnecessary invasive interventions, hospital admissions, and isolated death in ICU at end of life. So, in the provision of pediatric palliative oncology is by two means. The primary palliative care is provided by the pediatric oncologist managing pain and initiating goal-directed communication. And specialist palliative care is provided by pediatric palliative care specialists for managing complex needs. Both primary and specialist palliative care are provided in a planned, coordinated, timely, and flexible manner as directed by the need of the child and the family. The specialist CPC team consists of the child and the family. They are the core members of the team, and the other essential team members are physicians and nurses. The desirable members are social workers, psychologists, and other healthcare professionals, including interventional pain management specialists. It is child and family centered care, and it stresses the importance of family as the child's greatest advocate, and we work with the policy of non-abandonment. There are 4 guiding principles for CPC. You have to affirm dignity and respect for the child and the family, seamless information sharing, shared, informed, joint decision making, and using family feedback to develop new policies. Doctors inform parents and children wherever possible. They should take shared decision making through a collaborative process, which depends a lot on open, honest communication. Both the Royal College and the American Academy of Pediatrics, they advocate strongly for the participation of children in decision making to the extent that their ability allows. And age is not necessarily a good measure of decision-making capacity, although an arbitrary distinction of 18 years is drawn for legal purposes. For a child, the level of competence is based on his ability to provide a clinical history, his understanding about his disease, treatment options, and his understanding about the consequences of choosing one over the other. And it depends on the level of schooling of the child to some extent. And why do you need children's palliative care? Globally, about 8.2 million children need access to specialist CPC, and in India, it is about 1.6 million children. Although this palliative care has evolved over the last 30 years with varying models of care according to local resources and need, pediatric palliative medicine is only recently recognized globally as a super specialty. In India, palliative care for children began as a separate unit in Kerala and Delhi, and now it has spread to Hyderabad, Chennai, Mumbai, and Manipal. And most of the children's palliative care, they are provided by adult palliative care centers, and wherever it exists in India, CPCs are attached to pediatric departments of major hospitals. There are barriers to CPC. Parents are quite unrealistic in expectations and over optimistic in understanding of the child's prognosis, and so they go all out for curative therapy and not even ready to accept the child's bad prognosis and death. They are hesitant to enter into difficult discussions involving prognostication and end of life. Any child's death is accepted as a profound loss by the parents, siblings, their extended family, and the wider community. In developed nations, child mortality has fallen down to such an extent that death of a child seems utterly unnatural, and this has created a sense of alienation for families who are caring for the dying child or whose child has died. So from the healthcare professionals, there are certain barriers. They do not want to take away the hope or cause distress to the family. They are uncertain when to initiate difficult discussions regarding prognostication and end-of-life care, and they often equate palliative care with end-of-life care. Is it so? Is palliative care same as end-of-life care? No, it is not. So end-of-life care and terminal care, they are only part of palliative care, and there is transition from early palliative care to end-of-life care to terminal care, and finally to the active dying phase. And all these phases, they differ in the place, level, goals, and method of care. And there are clinical indicators for transition to end-of-life phase, terminal phase, or actively dying phase. And that is why I told you that palliative care is not just tender-loving care. It is an evidence-based medicine. So there are barriers from the health system, lack of finances, trained professionals, awareness in the public, and even in the policy makers. In India, there are no national studies regarding the magnitude of life-limiting illness in children. And as a result, these children, they have suboptimal symptom management, and most of these children, they die unnecessarily in hospitals in isolation. So what can be done? You have to dispel the myths about palliative care, that it is not only end-of-life care. It does not reduce hope or add distress to the family. In fact, it improves the quality of life and the quality of death and bereavement outcomes. The duration of hospital stay is decreased. Children undergo less aggressive interventions during their end of life. They are more likely to die in their preferred location, that is usually home. And there is greater opportunity for the child and the family to make choices, and family is less likely to express regrets over the choice of care plan or location of care, because they are well informed. So you have to incorporate palliative care principles in your daily practice. And this, as a result of this, you need palliative care training for all healthcare professionals. Integrated Child Protection Scheme and Rashtriya Bal Swasti Karyakram, they are all related to children with life-limiting illness. There are various professional training programs in pediatric palliative care, which are conducted by various organizations and institutions, and DM Pediatric Palliative Medicine is now in the pipeline. Usually we use life-threatening illness and life-limiting illness. These terms are usually used synonymously, but there is a little difference. Life-threatening illnesses are those where curative treatment is feasible but can fail. For example, cancer, organ failure. And life-limiting illnesses are those where there is no curative treatment, and these illnesses can be progressive, like cystic fibrosis, or sometimes these are non-progressive but irreversible, like cerebral palsy. In India, a large number of children live with these diseases like cancer, hematological conditions like sickle cell anemia, hemolytic disease of the, and then the congenital heart disease, neurologically handicapped children, chronic kidney disease, HIV, AIDS, diabetes, genetic and metabolic diseases, and so on. And out of these, neurological diseases and cancer, they are very important. So these group 1 diseases are life-threatening illnesses where curative therapy is available but may fail. If the treatment turns out to be successful, the child returns back to the normal functionality level, and then he is out of the purview of palliative care. But what if the treatment fails? The child's functionality goes down rapidly until the death of the child, and this child requires intensive palliative care till they die. So group 2 diseases are life-limiting illnesses. In these children also, premature death is inevitable, but these diseases, they have intense disease-directed therapy available, which can prolong life to some extent. And they need palliative care also in association with this disease-directed therapy for them to live with considerable quality of life. And group 3 diseases, these are diseases, again life-limiting illnesses, but unlike group 2 diseases, they don't have any disease-directed therapy available to prolong life, and their treatment is exclusively palliative. So these children, they die earlier than group 2 diseases, but as long as they live, they need intensive palliative care for maintaining reasonable level of comfort and quality. And group 4 diseases, these are non-progressive but irreversible disease. They start with a very low functionality even from the beginning, and although these are non-progressive diseases, they are irreversible, and so these children are also prone to premature death. But they are susceptible to catastrophic health complications like aspiration pneumonia, and sometimes they succumb to death out of these catastrophic episodes. And if they survive these episodes, they will come out to a functional level which is much lower than the pre-catastrophic incident level. And in this way, with repeated catastrophic episodes, their functionality goes on decreasing till they die. And so these children also need intensive palliative care. So in what setting can palliative care be delivered? It can be delivered in hospitals or hospices or at home. Children's hospices, they provide option for terminal care and respite care. Is there an ideal place? No, actually it is in a fluid state. Children and family will often move between the various settings according to their need, and it is important to have collaborative approach to care and make sure that communication flows easily and appropriately among these various stakeholders involved in this care because it is necessary to avoid confusion, intrusion, and replication of services. The specialist palliative care team can coordinate this care, and the key worker nominated in the CPC team can act as the first point of contact for the families. For a child, home is his castle, and children would love to be cared for in the midst of their family and friends. So if vibrant home care services is offered as a realistic option, most families wish to care for their sick children at home. Providing emotional and psychological support is also very essential because these children need not only palliation of symptoms, but also psychological, social, emotional, and spiritual support. These parents of these children, they feel helpless, hopeless, powerless, and they have fears and worries about their child's long-term survival, and they need to cope with their child's terminal illness, imminent death, and social stigma associated with alienation, and they need to cope with the intense needs of the ill child, and sometimes they have guilt feelings. Parents may feel that they fail to recognize and respond effectively to the symptoms of their child's illness. They may feel that their action or inaction has triggered the illness, or they may feel responsible if the illness is inherited, like fatal genetic diseases. And sometimes they may experience survivor guilt because it is generally believed that children are not supposed to die before their parents. And these parents, they may externalize these feelings and blame others, including the healthcare professionals. But it is important for us as healthcare professionals to understand their feelings, even though we may feel hurtful. So it is important not to become defensive or allow these hurtful feelings to have an impact on the care of the child. So what can be done through children's palliative care? You can provide excellent clinical control. You can take care of all the symptoms like pain, nausea, vomiting, constipation, dyspnea, seizures, spasticity, hiccups, siluria, and whatnot. And you can take care of the palliative care emergencies like bleeding, pain, spinal cord compression, superior vena cava obstruction, intestinal obstruction, hypercalcemia, etc., etc. And you can facilitate the child and the family to make choices, give them psychosocial support, give respite care to the family, relieve the family of the burden of care. And this provides leisure time and social interaction for the child and the siblings also. And this respite care can be provided at home or in a hospice. And you have to facilitate transition to adult services. As I told you, many children are now living into adulthood. Pharmacokinetics of drugs change, legal and ethical issues, needs, management options, settings, level, everything changes as the child develops into an adult. So, for example, a child with phantom limb pain after amputation and neuropathic pain after limb salvage, and these types of pain, they last for many, many years, and opioids are not going to be the answer for long-term pain. So you have to search other viable options like interventional pain management. You have to facilitate end-of-life planning, advanced care planning, tissue and organ donation, and bereavement support. So the three essential components for quality palliative care are teamwork and partnership, symptom relief, and psychological support. Teamwork is very important for shared care and coordination because palliative care involves multidisciplinary, multi-layered care, because together everyone achieves more. In pediatric palliative oncology, the CPC team need to coordinate with the primary pediatric oncologists, the volunteers, the home care teams, with the child and the family, and you have to make them convinced that whatever happens, we will be there for you throughout your illness journey, and you are not alone. Let us experience it together. The symptom management needs a scientific approach. Evaluation is very essential. It should be impeccable to pinpoint the cause of symptom. You have to explain to the child and the family about the cause of symptom, the treatment you are planning to give, the expected results, the side effects, the toxicities, and all these improve the compliance to therapy. And individualized management of each symptom is needed, as all symptoms are purely subjective, and you need to monitor. You have to monitor for the complaints to treatment, the effects, the side effects, the toxicities, and this is needed for choosing alternative drugs, or choosing the dose and dosage schedule of the drug. For this, you have to listen to the child and review the child frequently. And you have to pay attention to detail in all the 4 above steps. So the victim is never to assume, because to assume is to make an ass of you and me. So the general principles of symptom management include correcting the correctable, non-pharmacological therapy and symptomatic drug therapy. The aim is to help the child and the family move from being overwhelmed by a symptom to exercising mastery over it. For this, you have to aim for good enough relief, because we have to balance symptom control with function, and we should not expect immediate and complete relief, and we often need to compromise on complete relief in order to avoid unacceptable and unavoidable effects. And we should aim at chipping away the symptoms a little at a time, and don't expect once and forever relief, because all pains may recur and new pains may occur. So we can achieve more with determination and persistence. And you have to balance burden and benefit. The most appropriate route is oral, but if oral route is not feasible, you have to opt for drugs which can be given buccally or transdermally, because invasive measures are often avoided in children. Always assure practicality, accessibility, affordability, and acceptability. When an additional drug is considered, ask yourself, what are you expecting out of it? How can the result be monitored? What is the risk of undesirable effect? And what is the risk of drug interactions? And is it possible to stop any of the current medications? Because your goal is to reduce the pill burden also, because the child will be having multitude of symptoms and he'll be taking a lot many drugs. So will the patient actually take it? That is also need to be considered when you add a new drug to the prescription list. So what about pain in children's palliative care? Pain is very important in children's palliative care, because about 75% of the children with life-limiting illness, they have pain in the last weeks of life. And as you all know, pain is entirely subjective. It is what the patient says it hurts, and it is not purely a physiological process. It is a complex biopsychosocial phenomenon, and it is now identified as the 5th vital sign. Why? To facilitate accountability for pain assessment and management. And what is pain to a child? Structures for nociception are functional early in gestation. So the child feels pain even within the mother's womb. Actually, the younger the infant, the more intense will be the pain perception, because you all know that the inhibitory pain modulation develops only later in childhood, so their inhibitory pain modulation pathways are poorly developed. They have a larger receptive field, and there is increased concentration of substance P receptors. Pain can have immediate effects. It can have short-term effects and even long-term effects extending into the adulthood, but it doesn't really matter what the long-term consequences are. We should be controlling infants' pain because they are in pain and we are doctors, and what else would you do? So forget about the long-term consequences and just imagine what you would want if it was your baby in pain. So pain in children, they need more aggressive therapy, but in reality, their pain is grossly underdiagnosed, underrated, and undertreated. So cancer pain can be classified into nociceptive and neuropathic, with special mention to bone pain, muscle spasm pain, smooth muscle spasm, skeletal muscle spasm. All these can be painful, cerebral irritation, and inflammatory edema. Why? Because morphine is not the universal remedy or the ottamuli for all the cancer pains, as it is generally believed by all the oncologists. Pain can be opioid sensitive or it can be opioid insensitive, especially these types of pains. In certain cases, it is only partially sensitive to morphine, and you have to combine other drugs also. So pain in cancer can be due to due to cancer itself or due to its treatment. It can be due to debility associated with cancer. It can be unrelated to cancer, and it can be due to invasive procedures which can be diagnostic and therapeutic. Children with cancer, they have pain often of more than one cause, often of more than one type, and their perception and tolerance of pain varies widely. And this is why the pain management in children becomes very complex. So in life-limiting illness, pain results from a complex interplay of physical, psychological, social, and spiritual factors. And this is the concept of total pain. And this was first put forward by Dame Cicely Saunders. Severity of pain may be exacerbated by lack of sleep, lack of understanding, anxiety, depression, spiritual sufferings, and social isolation. Because you aim at total pain management, you need an interdisciplinary team to manage total pain. But you have to differentiate pain experience from pain biology. Pain experience depends a lot on individual interpretation, and it is purely subjective, and it is the distress or the pain experience, which is the subjective negative experience of pain, which we want to treat, and we want to treat the pain experience and not the pain biology. So the unmanaged pain results in distressed child, angry and unsatisfied parents, frustrated physicians, and lack of complaints to therapy. So the scientific approach to cancer pain management is the same as that for other symptom management, but is it always possible never to assume in a child? If the child can talk, self-report is the best approach to pain assessment. But non-verbal young infants, they are unable to describe their pain sensation. So we have to guess when they are in pain. Unlike adults, these children, they cannot rationalize pain, because adults can limit the distress due to a painful intervention through rationalization. That is by thinking that it is for a good cause, and this is not there for children. So extra caution is required for children. We sometimes need to err on the side of caution, and we are forced to make assumptions regarding pain estimation in children. And I would rather say that it is our ethical responsibility to assume pain in non-verbal young children. And I think it is much worse to ignore pain in a vulnerable population than to occasionally provide unnecessary treatment. Describing pain only in terms of its intensity is like describing music only in terms of its loudness, because quality of the music depends on many factors: the voice of the singer, the tone, the pitch, the instruments used, etc., etc. And the pain assessment includes history examination assisted by pain assessment tools. Nothing can beat a proper history and physical examination. You need a detailed assessment of pain because you have to identify the cause of pain and the type of pain, because different types of pain in cancer differ in quality and all these characteristics. And it is also important to identify the meaning of pain, because the meaning of persistent pain in advanced cancer is I am incurable and I am going to die. And you have also to assess the impact of pain on sleep, mood, and activities of daily living, especially in older children. And this depends a lot on child's understanding about his health and illness. And this understanding occurs through stages. And these stages are related to the developmental age, his disease experience, and where the child stands in his disease journey. Age of the child is may not be a determining factor always, because a younger child with a chronic illness, through his experience and that of the fellow patients he has been seeing for a long time in his disease journey, and he will be in a higher stage of understanding about his illness than an older child with no previous medical history. For example, an 8-year-old Ajit, he has seen another 8-year-old boy, Rahul, who was lying next to him in the ward, and he has seen Rahul developing red spots all over the body and bleeding from the nose, and Rahul was taken to ICU and he never returned. So if Ajit develops similar red spots or bleeding, he quickly understands that he is also going to be taken to ICU, and that he would think that he is never going to come back. So you have to ask the child about his understanding about his illness. There are various pain assessment tools to help you, but all these validated pain assessment tools in children, they have one fatal weakness. They are validated using a guess about the child's pain, and they are all based on observation, and observation doesn't work perfect always. So although it is okay to consider these tools, it is important to recognize that they are imperfect. And the safest approach, I think, is to assume the highest estimate of pain in a young non-verbal child. But for an older child, you can give the child a body chart showing the front and the back of the body, and ask the child to share the areas of the body which hurts using different colors. And this is called giving color to pain. So various painful procedures are performed in pediatric oncology, like IV access, central venous access, lumbar puncture, bone marrow biopsy, Then the intrathecal drug administration, ING, wound dressing, wound debridement, etc., etc. And you can use pharmacological methods like EMLA cream, and you can use local anesthetic infiltration, but always take precautions not to inflict additional pain while giving local anesthetic infiltration. You can do this by buffering with bicarbonate, warming the solution, using the smallest possible needle or the smallest volume possible, pre-application with EMLA, distracting the child or infiltrating the local anesthetic slowly. And in some cases, you need nerve blocks. In some cases, you can use simple analgesics like paracetamol. And for more painful procedures, you may need opioid analgesia and sometimes procedural sedation using low-dose ketamine, nitrous oxide, and sometimes you can use intranasal anxiolysis using ketamine, midazolam, and fentanyl. The presence of the parent can be pacifying to the child. You can do sensorial saturation, that is engaging visual, auditory, tactile, and gustatory sensation to distract the child using sucrose solution in newborns, non-nutritive sucking, swaddling, rocking, holding, etc. Because all these have shown to decrease crying and behavioral pain scores. You can use psychological methods like distracting the child from painful procedures. For older children, you can ask them to take deep breath, and explanation, pep talks, music, and video games. All these are helpful. So there are certain procedural precautions. Whenever you give an intramuscular injection, even though that is not advisable, you have to give intramuscular injections rapidly with no aspiration. You have to convince the nurse that no need to aspirate. And you can club the painful procedures together and try to perform the most painful procedure as the last one. For example, if you plan to have an IV cannulation and a lumbar puncture, do IV cannulation first and then go for lumbar puncture. Limiting painful procedure is also important, but when a procedure is necessary, just get it done and do not withhold it because it is painful, because if you withhold it, it can result in more distress to the child. For example, an abscess which needs drainage. But keep in mind that there is no one size fits all option, and most scenarios, they call for more than one option. For example, in lumbar puncture, you may need to combine EMLA, extra local anesthetic infiltration, anxiolytics, and non-pharmacological techniques. You believe the child and believe that the pain is as severe as the child says it is, and individualize your approach to each child. Reassess at regular intervals, and always assess and manage the psychosocial impact for total pain management. The principles are the same as that for other symptom management. We use the same 3-step WHO pain ladder for older children as we use for in adults. Step 1 includes paracetamol and NSAIDs for mild pain. Step 2 includes codeine, tramadol, and tapentadol. These are weak opioids for moderate pain. And step 3 for severe pain, which is taken care of by morphine, fentanyl, and methadone. Adjuvants need to be considered at each stage, especially in those difficult to manage pain, which needs special mention. And drugs need to be prescribed as PRN for breakthrough pain, which is the pain that breaks through the base level of analgesia. The drugs for breakthrough pain should be rapidly acting, and they should have shorter duration of action. And we need to carefully adjust the drugs and the dosage schedule for controlling this breakthrough pain to avoid overdose and toxicities. For younger children below 7 years, 6 years, we use a 2-step ladder. The step 2 of the 3-step ladder is avoided. And for moderate pain, we use low-dose strong opioids like morphine, fentanyl, and methadone, because codeine is often not used in children's palliative care because it is very constipating. It has got a ceiling effect. And as you know, codeine acts by getting converted to morphine in the body. And 10% of children, they won't convert codeine into morphine. And so codeine won't act in such children. And some children are ultra rapid converters, and they can result in morphine. They can have morphine toxicity. Also, as you all know, tramadol lowers the seizure threshold, and so it is avoided in very young children. Adjuvant analgesics are very important, especially for special mention pains like neuropathic pain, bone pain, pain due to muscle spasm, cerebral irritation, and inflammatory edema. And these are the anticonvulsants and tricyclic antidepressants, the bisphosphonates, the steroids. All these are used as adjuvant analgesics. And the general principles of analgesic therapy is go by the appropriate route, go by the clock, because the regularity of analgesic administration is crucial for adequate treatment of pain, and always go by the ladder for the child with attention to detail on all the 4 above steps. And there are a lot of myths concerned with opioids, and the answer to all these is a big no. And there is a concern regarding addiction, especially when morphine is used in children, and there is concern regarding shortening of the survival. But the answer to all these is a big no, because the more aggressive the disease is, the more painful it will be, and then it necessitates opioid use. So the primary association is between the severity of disease and the shortened survival, and it has nothing to do with the opioids. The modified WHO ladder consists of a fourth step to allow for interventional pain management in patients who have severe to very severe intractable pain. That happens in about 10 to 15% patients. In children, we use IPM approaches in those who do not respond to any of the foregoing measures, and in those where regular medication is practically difficult or poorly tolerated, and in chronic pain in cancer survivors like phantom limb pain and neuropathic pain following limb salvage surgery. And these pains extend into the life adulthood. And as I said, opioids are not the answer for this long-term pain, and you have to give interventional pain management techniques. And in case of pain localized to few dermatomes like pleural or rib metastasis, you can go for interventional pain management techniques. And it should not be reserved as the fourth step, because combination of pharmacologic and interventional therapy provides superior quality of analgesia over either strategy alone. But the availability of such interventions varies widely. The interventional strategies include nerve blocks, which can be peripheral nerve blocks or sympathetic nerve blocks, and this also include neuraxial and neuromodulation techniques. So in nerve blocks, we block the transmission of pain impulses through the peripheral and sympathetic nerves, but you have to perform diagnostic block first. And if it turns out to be successful, go for a prolonged pain relief using cryoablation, radiofrequency ablation, or chemical neurolysis, and the use of MH guidance, ultrasound, fluoroscopy, CT, MRI, all these have improved the success rate and limited the complication rate. So intrathecal drug delivery system is very expensive. Here we use a tunneled intrathecal catheter with an implantable infusion pump, and an additional patient-controlled analgesia device is provided for additional boluses for pain relief if required. But for children with limited life expectancy, you have to opt for less expensive procedures like tunneled epidural catheters, where you use a percutaneous elastic catheter which is connected to an external pump, or you can use an elastomeric pump which you need to refill every 3 days. So intrathecal neurolysis is used to treat intractable cancer pain in localized area where the dorsal nerve rootlets are targeted using chemical and physical agents. The neuromodulation techniques include the TENS, the scrambler therapy, the spinal cord stimulation, and all these are based on gate control theory of pain. In TENS and scrambler therapy, these are non-invasive interventions. Here, adhesive electrodes are placed on the skin, and these electrodes receive electrical impulses generated by the TENS machine or the scrambler therapy machine. But the benefit of TENS in long-term chronic cancer pain is the neuropathic pain that remains controversial, because TENS is sort of intruding into the body's pain perception mechanism. And with continued use of TENS, our brain will be able to distinguish this artificial signal, and so TENS will be eventually of no use. But in scrambler therapy, artificial intelligence is used to deliver the impulses by adapting to the body's pain perception mechanism. So there is no rejection by the brain on long-term use. Scrambler therapy also gives rejuvenating electrical signals, which allows natural healing of the damage. So this is useful for long-term pain control. Spinal cord stimulation is a minimally invasive neuromodulation technique where the electrodes are placed on the spinal cord, and an implanted pulse generator delivers electrical impulses. And this is also beneficial for refractory neuropathic cancer pain like phantom limb pain and neuropathic pain following limb salvage surgery in children extending into adulthood. So don't forget about the non-pharmacological interventions and management of other symptoms. You have to give supportive therapy, behavioral therapy, physiotherapy, and occupational therapy, etc. as needed. And you can use diversional therapies like drawing, playing in individual or in groups, music therapy, relaxation techniques, outings, because you are dealing with chronic pain. The presence of parents, toys, frocks, candles, all these can be comforting to the child. So the goal is to provide optimal quality of life. And for this, you need to impeccably assess the distressing symptoms and learn about the child and the family. And this needs excellent communication, but spoken, and you have to, the language you used is very important, but spoken language has limitation because children may be pre-verbal, non-verbal, cognitively impaired, or frightened. So communication with children is very important. Children use their whole body to communicate, and they listen to our whole body. They use, in addition to spoken language, they use body language and play language, and you have to identify the body languages, because all sleeps are not the same, and this is sleeping with pain and this is sleeping without pain, and all plays are also not the same. So never ever underestimate the children, because usually these parents, they falsely assume that the child knows very little and they want to protect their child from the bad news. But children often know a great deal about their illness and the prognosis even. But they may not reveal this because they fear of upsetting their parents. So this is called mutual pretense, and these children are very skilled at observation and interpretation of adult behavior, and sometimes they generate fantasies to explain the unusual behavior of their parents, and these notions may result in more distress to the child. And the children's concept about death is also different. Most of the adults fear the process of dying and death, whereas the child's greatest fear related to death is immobility and separation from parents. So you need to explore what the child knows, because children generally know the answer to the question before they ask. So before answering, find exactly what the child wants to know, because the real question may be something completely different. If the child asks you, am I dying? Just ask back, why are you asking this? And why do you think so? And because his concern may be something very different, like unrevealed or unrelieved pain or feeling of abandonment by parents. And don't be judgmental and don't be patronizing, and don't argue with the child or with the parents, because children don't like somebody quarreling with their parents. Use speak in the developmentally appropriate language that the child understands, and get down to the child's level. The communication is very complex in children's palliative care, especially with siblings, because we need to have open conversation with the siblings and other older children in the family, because they often feel forgotten, they feel neglected, they may be jealous of the patient's attention, and they may have guilt feelings, sadness, or anger, and sometimes they show attention seeking behavior, or sometimes they have mild somatic symptoms. And you have to facilitate parents to maintain normal levels of care and attention to the healthy siblings. So what about ethics in children's palliative care? Children's ethics, they differ from adults, especially regarding autonomy, informed consent, refusal of consent, and parental overruling of the child's decision. So children should be made to participate in decision making, as I've already told, because empowering children will have a positive impact on their experience of care. And do these children need spiritual support? When you hear a 5-year-old child asking, will Amma forget me after some time? Or another 4-year-old child consoling her mother by telling, don't cry, Amma, I will not die. I will not go away. I will come back as Kunyava. And you need to realize that these children are in spiritual distress. And the common spiritual concerns are love, hope, wish, need, forgiveness, safety, separation, legacy, etc., etc. And sometimes, the spirituality in a child will be closely associated with his cultural or his religious belief. And this 12-year-old boy with extensive scalp tumor, bleeding scalp tumor, he appeared very disturbed in the ward, and he once told the ward nurse that he wanted to confess. And he belonged to a Catholic community, and we usually don't expect children asking for confession. Anyway, the priest was called in and the boy confessed. And to everybody's surprise, he remained peaceful after confession for a couple of weeks and died peacefully. And do these children know that they are dying? These are some of the real life stories shared by senior pediatricians from their long-term experience with children having serious health-related sufferings. Because my experience in children's palliative care is very limited. This is the story of a 7-year-old boy with leukemia, and he was from a poor socioeconomic class, and his mother was a housemate. She was a single parent also. The child, he used to have recurrent fever and respiratory infections, and each time he had these problems, his mother used to take him to the nearby pediatrician, and she had to pay 200 rupees for each consultation, and she struggled a lot for finding this money. And this boy, he has been watching this all these days, and he used to tell his mother that he wanted to become a pediatrician. But later on, he became very sick and was admitted in the ward. And through his life experience, the poor boy, he understood that he is not going to get better anymore, and he's going to die soon. So one day he told the ward nurse that I cannot become a doctor, but my brother will become a doctor. He will become a pediatrician who looks after kids without fees. And do not guess, identify the real concerns, especially in older children. Let the child express his fears, worries, wishes, needs, concerns, and don't assume. And this 15-year-old girl diagnosed with osteosarcoma was posted for below knee amputation. And on the preoperative day, the surgical team and the anesthetist, they visited the girl, and she appeared worried. And the team asked her about her concerns, and they were expecting her to tell them about fear of surgery, fear of post-operative pain, etc. And they were all prepared to tell her about anxiety and pain relief. So this girl, she remained in silence for a couple of minutes and then said, I love wearing anklets and I have many pairs of fancy anklets with me. And if you take away my leg, where will I wear my anklets? And although it was surprising for them, the surgical team utilized this opportunity to explain about the different prosthetic devices, and she got convinced that she could wear her lovely anklets even after surgery. And continuing futile treatment. And this is a very common scenario in pediatric cancers, and this needs sensitive communication with the family regarding the concept of medical futility. Decision making is not a one-time event. It is a process, and we as physicians should do more than offering a menu of choices. And we should recommend what we believe is the best option for the child at that situation, and we should give reasons for such judgments based on medical and moral factors. Disagreements between parents and clinician can occur. Sometimes these parents, they may insist on continuing inappropriate therapy, and sometimes they may refuse potentially beneficial therapy. And these disagreements are often resolved by open, honest communication. In pediatric oncology, we have to use surgery, radiation, chemotherapy judiciously to balance the benefit and the burden. The benefits include prolonging life with reasonable quality or providing symptom relief, and the burdens are the toxicities, the side effects, as well as the financial toxicity. The goal of end-of-life care includes effective symptom control and good psychosocial care, and you have to take care not to inflict more distress to the child and the family. And for this, you need to avoid unnecessary interventions. Before planning for any new interventions, ask yourself, how is that intervention going to change the outcome? Is it going to cure the disease? Is it going to prevent the progression of the disease? What is the impact of this intervention on quality of life? Will it improve the symptoms? Will it make the child feel worse? And if so, how long will he feel worse? And what will happen without interventions? So in case of intractable symptoms at the end of life, you go for palliative sedation sometimes. And this is based on the principle of double effect. And this doctrine says that if doing something morally good has a morally bad side effect also, it is ethically okay to do it, provided the bad side effect was not intended. Here, the death, if occurs, is attributed to illness and not due to our sedation. So at the time of death, be there giving psychological support for the child and the family, and provide bereavement support, identify those who need this special help during bereavement, and volunteers with special training may be helpful to give bereavement support to the family. How people die always remains in the memory of those who live on. So remember, palliative care is not just tender loving care. It is not only end-of-life care. It is not only for those with incurable cancer. It is a low-tech and high-touch approach, and children have the right to live with dignity and the right to die with dignity when it is time to go. And every child with a cancer diagnosis has the right to receive palliative care. always hope for the best, but be prepared for the worst, and aim to help the child to live as good as possible for as long as possible, because your goal is to add life to child's years and not just years to the child's life. And you should have the conviction you can, and you should have the hope you will be, and be the change you want to see in the world. But when you want to change something for good, quite often you may not get it done, and this makes you angry, and anger in compassion is the catalyst for change. Thank you all for this patient listening. Thank you.